Good evening, Hudedar. Rakesh, make Dr. Hudedar co-host.
Good evening.
Good evening. Today, again, the second ward round. We'll have 6 cases.
Yeah.
And I think today is the last clinic because the exams have already started.
Yeah.
So I think some students have already appeared on 14th, 15th.
Oh,
I mean, yesterday and today.
yeah.
The next exam is on 25th, 26th, 27th, and I think 29, 30. And 22nd, 23rd. So 22nd, 23rd, then 25, 26, 27, 28, and 29, 30. So these are the different centers where the exams are being conducted.
Yeah.
So today we'll start after 8-10 minutes.
Yeah.
And because I think students will be less today.
Hmm.
Many are either preparing for the exams or might have finished their exams also.
Finished. Yeah.
Yeah. We'll just wait, Doctor.
Yeah.
I don't know.
Sure.
Yeah, Dr. Gite has also joined.
Sir, good evening. Good evening,
Good
sir.
evening. Yeah. We wait for some time till 9-10, and then we will.
Okay, sir.
We'll start because number of students will be less.
Sir, who will be answering today? Abhishek, sir?
Yes, I will be
OJ, sir.
answering.
And OJ is also this.
Thank you. Thank you.
Hello.
Yeah. You are also answering?
Sir, yes, sir. I'm also answering.
Okay, so Prashant, who else is there? Anyone else is there to answer? Anyone is willing?
Good evening, Pankaj sir.
गुड इवनिंग डॉक्टर गीते, कैसे हैं?
बस मजे में हूँ सर.
आज सुबह ही वापस आए, काफी इंटरेस्टिंग रहा.
How was the conference, sir?
Conference was very good. Very big meeting, means there were simultaneously around 10 halls. And interesting, 2 days were packed with uro-oncology.
अरे वाह.
So
we have all you have all 3 to 4 days presentation daily.
I had presentations every day. Total 9 थे सब.
अरे
5 lecture और 4 poster. अच्छा था, enjoyable meeting. There was a very big Indian contingent. Luckily, पहले 7 दिन the temperatures were also very friendly. Means the temperature were between 10 to 14. Last day it went towards 0.
यस SIU का रजिस्ट्रेशन कर देता हूँ सर. एग्जैक्टली मुझे थोड़ा लिंक होगा तो बोल दो. मैं किया नहीं एक्चुअली.
ठीक है,
क्योंकि एटलीस्ट रजिस्ट्रेशन तो रहना चाहिए ना.
हाँ बिल्कुल, मेंबरशिप होना ही चाहिए. और क्या है, देखिए नेक्स्ट मीटिंग उसका इस्तांबुल में है, उसके बाद का इंडिया में ही है, दिल्ली में है. तो इट्स अ गुड मीटिंग है ना. देखिए एसआईयू का फायदा ये है, दिस इज द ओनली बिग प्लेटफॉर्म जहां हम लोग एज फुल मेंबर जाते हैं. बाकी आप EAU, AUA कहीं भी जाओ तो यू आर ऑलवेज एसोसिएट मेंबर और इंटरनेशनल मेंबर विदाउट एनी राइट्स. Here it is like, it can be something like our own association.
It's like USA only.
Yes. So abhi like last year president was Dr. Sanjay Kulkarni. After 1 year president will be Rajiv Kumar. तो उसमें इंडियंस का अच्छा प्रेजेंस भी अच्छा है.
कंट्रीब्यूशन रहेगा.
हाँ.
बीच में बॉम्बे आके गया 2-3 दिन के लिए. आप चले गए तो
ओके
मिलना नहीं हुआ. तो फिर गौरंग शाह सर से मिला. पाथरीकर मिला था. लकीली सेम प्लेस पे रहते हैं ना.
राइट. बाकी आपका ठीक चल रहा है?
हाँ सर, अभी वो लोकल किटीकॉन में थोड़ा सा इन्वॉल्वमेंट है,
हम्म
कॉन्फ्रेंस में जो भी पॉसिबल है मेरे तरफ से कर रहा हूँ हेल्प उनको। कुछ लोकल गवर्नमेंट ऑर्गेनाइजेशनल रिलेटेड इश्यूज थे तो उनमें किया, हेल्प पॉसिबल था मेरे से।
बढ़िया बढ़िया बढ़िया।
हाँ, तो बाकी प्रेजेंटेशन आज सच तो कुछ नहीं, लेकिन जो भी वसवाल सर दे देंगे काम वो करने का प्लान है बस, बाकी कुछ।
मेरे भी पीछे पड़ा है कि मैं अटेंड करूं, पर मेरा अभी श्योर नहीं है मैं आ पाऊंगा या नहीं। यार बहुत ज्यादा हो जाता है ये, अभी 10 दिन ये हो गए। अभी 17, 18, 19 अहमदाबाद में है।
और
Yes, Pankaj,
हेलो सर, कैसे हैं?
congratulations.
थैंक यू सर।
Good, good. So, I told him, Dr. Gite,
Sure.
we are so lucky that we have got Pankaj with us in our teaching program and Ganesh. So, because of them, we are able to deliver,
नहीं सर, इट इज ऑल
good knowledge to
कंप्लीटली
our students.
आप लोगों का एफर्ट है। हम तो वो सपोर्टिंग रोल प्ले करते हैं, मेन
अरे,
हीरो तो
whatever
आप
it is.
बट कंबाइनली इट इज क्या है कि सब स्पेशलिटी के जैसा हर एक अपना अपना एरिया में थोड़ा थोड़ा।
हाँ बिल्कुल बिल्कुल
हाँ।
बिल्कुल।
Then the important thing is that we are also getting knowledge and we are getting trained how to train our students. Basically, what they need. So over the period, we are also becoming better.
Yes sir, definitely it's a learning experience. क्यों हम वेट कर रहे हैं?
Yes, we can start. It is 24 candidate now, including us. This is the last class, sir, because
Okay.
exam is already on. Few people already have given their exam on 15th and 16th. तो remaining कुछ एग्जाम्स चल रहे तो शायद अभी एग्जाम में और डिस्टर्ब करने का कुछ मतलब नहीं। बेटर वी विल गिव टाइम टू स्टडी देम।
Yeah,
बिल्कुल बिल्कुल बिल्कुल।
correct. So I think we should start now. And we have got 6 cases for the board round. So first, who is answering? Abhishek, I think he has not joined. My Paras was busy in some surgery. He's just joining. Once he starts sharing, we will see. So Pankaj bhai, now over the period we have evolved and we are making changes also. So if you, after going to Montreal and attending all these, your different clinics, if you have got any better idea, just let us know.
Surely.
If you think that, yeah, because we have to keep on improvising. We can't say that that is the best way to what we are doing.
Absolutely.
So initially we were having only one case and then discussion right up to theory. Then in that we started adding different types of cases, similar cases. So instead of one case, we had 3-4 different scenarios. Then tables, vivas and other things. So in between we want to take the lectures also. So the topics that we have to decide. So we can, now the next year student, we can request them that which are the topics which they want us to cover. That is the one thing. And then you are in this SIU group also in the teaching program. So from that also you can take some ideas and
So
put it forward.
I also sometimes attend this PG activity of UCI, urology clinics of, I think,
Indian Institute, Indian Urology Society, na?
नहीं, कैलिफोर्निया का यूरोलॉजी डिपार्टमेंट का पीजी एक्टिविटी होता है। हाँ, तो उसके मैं आपको प्रोसीजर्स बताता हूँ, हम लोग बाद में बात करते हैं। So what they do is, means every time they will have one speaker who gives a short talk.
Okay.
Then on the same topic, they have one case discussion.
Okay.
And then they also have one small quiz at the end.
Okay.
Okay, there is a online platform which is called as, let me just check, I'll tell you. Jisme you ask questions and people can put in their answers. And that platform itself gives the score to the person.
Okay.
So the score is dependent on how fast you answer, and obviously it should be correct and fast. So एक उसको हम ऐड कर सकते हैं, but हाँ सब बीच बीच में proper lectures are important.
Fine. So that in the beginning we had arranged. You
Right.
remember?
Right. Yes.
So,
yes.
Yeah. So that is what I think we can start doing. So this idea is also good. Thoda modification we can do it in that way.
Yes, definitely.
Yeah. So let us one of the now when we start after 1.5 month, that time we will experiment this. As you are
पहले
saying.
एक बार शुरू करने के पहले आप में डॉक्टर गीते हम 4-5 लोग एक बार एक जूम मीटिंग कर लेंगे, डिस्कस कर लेंगे.
Correct.
और उसके बाद फ्लोट करते हैं.
Sure, we'll do that.
हाँ जी.
Okay, I think we should start now.
Yes.
Yeah. Yeah, who is answering?
Sir, I'm answering, sir.
Okay, Abhishek will be answering
yes.
first. Yeah. Bharat, case 1. Ajay, this is case, last time's case, na?
Yes.
Okay.
A 28-year-old gentleman presented with left flank pain with hematuria since 7 days. On examination, abdomen is soft and non-tender. Left renal angle tenderness is present. Past history of left URS with DJ stenting 2 years back, no record available. No comorbidities. On investigation, hemoglobin is 13.2, TLC is 15,400, serum creatinine is 1.5. And this is the X-ray which we have done.
Yes. So Abhishek.
Yeah. Yes, sir. So, sir, this is an X-ray KUB showing the ribs, the spine, and the pelvis region, sir. And then I can see a DJ stent in situ on the left side with the calculus that can be seen at the left renal area, sir. And there appears to be encrustations also along the DJ stent, sir. So this DJ stenting was done 2 years back, sir. So this appears to be a forgotten DJ stent, and there appears to be encrustations and calculations on the middle part of the DJ stent.
So now this patient has come to see you in your OPD. He is not admitted.
Yes, sir.
Right? So this is a walk down. This is not a case. Full history and other things are not very important. So
yes, sir.
Now after this, how you are going to guide this patient? What you are going to tell him?
So this
fellow has come to you after 2 years, and this is your patient.
Yes, sir. So, sir, sir, he has come with a history of flank pain since 7 days, sir, plus hematuria.
Abhishek, it is very simple. He is your patient. You know his history. History is over. In
yes,
this
sir.
case, this is not very important. You know everything. This patient has come to you. So what is this? It is a forgotten
So
stent.
it is a forgotten DJ stent. Yes, sir.
So now whose fault it is?
Sir, it is actually the part the operating surgeon's fault also, and the part the patient's fault also, sir. The operating surgeon should have communicated properly that the stent needs to be removed.
No, but that is what I'm saying. This is your case.
Okay. Okay.
He
yes,
has
sir.
come to you after 2 years. How you are going to start? Are you going to say, I'm sorry, I didn't tell you? Or you are going to tell him, you are going to accuse him, why didn't you come? How you
No,
are going
sir.
to start?
Yes, sir. Sir, I'll start by apologizing about the communication gap.
Apologizing. If you apologize, you are gone.
Yes, sir. So, sir, regarding my communication gap, that I was not able to convey to the patient that objectively that the stent needs to be removed, sir. That, and regarding the patient's
Not
compliance.
necessarily, Abhishek, not necessarily. That is what I'm telling you. so many times, you can always tell him, "Ke bhai, you have forgotten this. Why didn't you come to me for the follow-up? I have explained you there is a DJ stent inside. I have written down in your discharge card that you have to come for the DJ removal. I have written in the operation notes that DJ stent is kept in your system. Before surgery also I had explained you. You should have come for the DJ removal. Why didn't you come?"
Yes, sir.
So don't take a blame on you, first of all. At the same time, don't be rough on the patient.
Yes, sir.
You try to tell him that I have communicated with you, why you are not come, what was the problem? And then the patient will tell you, "I'm sorry, sir, I was not aware," or whatever it is. Then you specify and say, okay. In our country, we can do to some extent.
Yes, sir.
That is the first thing. Dr. Gite, what is your say?
Yes, sir. First thing, if this is my patient, I will check his discharge card.
Yeah.
Right, sir.
I have written on the discharge card to he should come for the digestion removal or not. And as per that, I have to modify myself. If I have written, then I will explain him. I have already written, you should have come. Anyhow, if you have not come, you may have some problem. I will convince him. I will explain the current situation and explain the treatment required. This is one way. Another way is if I have not written, then if he may go to different urologist. He may have seen already some other urologist. That urologist may have told something wrong thing about me. So I have to explain that I have placed the stent. Anyhow, it is missed by you as well as me. I have written in the operation theater, operation notes probably. Operation notes में तो पक्का लिखे वाला रहेगा. Discharge card में 6 week के बाद में आना है ऐसा लिखा नहीं है. Lekin it is considered that during operation I have explained, I have placed one pipe inside your body. So that body is foreign body and you have to come for removal of that. So थोड़ा डिफेंसिव मोड में रह के कन्विंस करना पड़ेगा अगर लिखा नहीं है तो. और अगर लिखा है तो कॉन्फिडेंस के साथ उसको समझाना पड़ेगा. वो एक फेज होने के बाद में that this patient is already in the sepsis. So TLC is raised, local tenderness is there. The coil of the digestant, lower coil of the digestant is comparatively higher than the normal, which is seen on the X-ray. That is at the level of ischial spine. Usually it is not at the level of ischial spine. Usually it is hanging over just that symphysis pubis joint. It may be the dilated ureter. It may be due to the sepsis, may be due to the obstruction caused by the para-stent calculi or caused by the formation of the biofilm over the digestant. So this needs to be tackled initially by the X-ray QB only is not sufficient. So I will admit the patient. I will start the injectable antibiotic, send the urine culture, check the if serum creatinine is 1.5. So if required, I will hydrate the patient and go for CT-IVP. Or sonography and CT-IVP. Sonography, if it is suggested of internal echoes, then I have to replace the stent if it is possible. Otherwise, I have to place the PCN. And if it is no internal echoes, then CT-IVP and proceed after settling the TLC and clinical findings on the in the loin. That's what the plan of mine for this type of patient.
So Abhishek, when
Yes,
you
sir.
put a DJ stent,
Yes, sir.
what are the different ways now when you are going to start your practice? How
Yes, sir.
you are going to see that patient comes back to you? So what will be your plan now? Tell me.
So, sir, to ensure follow-up of this patient, sir, I will communicate properly with the patient, sir, that a DJ stent is in situ, it is a foreign body, and it eventually has to be removed, and the time of interval of removal is so and so time, sir. That I will communicate properly with the patient, sir. Secondly, I will explain the complications associated with the forgotten DJ stent, sir. That is calculus, complications associated with calculus, sir, which may be
Abhishek,
obstruction.
question is very simple.
Yes, sir.
What are the steps you will take to ensure that patient's DJ stent is removed in proper time? Just tell me.
Sir, proper communication with the patient and his relatives, sir. I will maintain. If
Beta,
the
there are
patient,
definite steps. You just tell me 1, 2, 3, 4, 5. Just tell me. Number one,
Yes, sir.
pre-operatively, you will explain and you will write it down in the consent that patient will have to come for the DJ removal. Number two,
Right, sir.
in the operative note, you will write down and you will, in that also you write that patient has been explained about this and he has to come for DJ removal. When you are going on a round, you must write down on the paper that patient has been explained that he has to come for DJ removal. When you are putting a discharge on the discharge card, you have to write it down. Preferably many people, what they are doing is they are taking the DJ stands, one of the marker or whatever, it is there on the DJ stand, and they stick it on the discharge card. And on that, with the red pen, they write down. So when he comes back, they remove that. Third thing is, many people, what they do is they book operation theater only after 21 days or whatever time is. So, and with the telephone number. So automatically, like in a big hospital, they always ask you, okay, your patient is there for tomorrow for DJ removal. So so you can inform him. In between, you have to telephone him, or you have to SMS him, or you have to send email, or you have to send by the postcard. And you have to communicate with him. These are the ways. In spite of that, if he doesn't come for a DJ removal, then it is a contributory negligence on his part, and you will not be sued for that.
Right, sir.
Okay?
Yes.
So this is a simple question, simple answer. Don't go into, I will explain him about a complication. We are not asking you about this.
Okay,
Because
sir.
nowadays it is happening and we are getting a call
Right.
from the lawyers also. So these are the steps to everyone. Pankaj bhai, you want to add anything?
No, sir, I think you have covered everything absolutely well. So basically, we need to remember that irrespective whether you write patient has forgotten, whatever has happened, we are still responsible for the stent to come out. Means we have to, if it goes to the stage of court of law, we need to show that adequate attempt has been made from our side to remind the patient. Just writing on the discharge card or writing on the paper is not enough. So the court will say, you have put the stent, you need to remove the stent. So medico-legally, it is our responsibility. So apart from what Sir has said, these days there are also apps which will remind the patient as well as the doctor about the time of stent removal. And I think Cipla company had once come up with one such app.
Yes, absolutely right. That's also a very good app one can add into it. So
Sir,
please remember. Okay,
we
so
have
now Abhishek, this is a case.
Yes,
And
sir.
everything is over. Patient is now he's very mild and he has told you sorry and all these things. Now, what are the things you will do? What you will explain him?
So I
Tell
will
me directly
explain.
about the removal of the DJ stand. How you are going to proceed? Let us.
Yes. Yes, sir. Regarding the removal of the digestant, sir, sir, I will give a single attempt at, once the patient is stabilized, sir, and the counts have come down, creatinine has reduced, sir. I will give a single attempt at removing the digestant under cystoscopic guidance. If any pressure, if any resistance is felt, sir, then I will not attempt that. And I will explain the patient regarding the ESWL of the ESWL of the calculation calculi. And then, sir, attempt at removing the stent, sir, once the calculus and the encrustations are removed, sir.
Abhishek,
And
when
if
you will
that
give
doesn't work, then
ESWL?
third stage. If that doesn't work, then third stage will be RRS and fourth stage will be PCNR.
I am absolutely unhappy with the Abhishek answer.
Yes.
Yes.
She just see the X-ray QEB. We have not done anything except stabilization by giving the antibiotic. That's what you are told. So how you judge that the stent is going to come out or not? That is one way. Another is what is the current status of system? Functionally isolized parenchyma-wise. For that, any one investigation. Suppose the system is totally gone. So the removal of stent is not going to help. Again, this system has if it is functioning, there is a big stone in the kidney, pelvis probably, renal pelvis. and there is a chain of stone in the ureter. So how your ESW is going to help in this case? At which place you will give the ESW?
So Abhishek, दोनों चीजें acceptable नहीं है. Attempt to remove the stent is not going to work with such a big stone that has formed on the renal coil. We don't expect the stone to come out by cystoscopically. So whenever you are asked treatment for a neglected stent on which there are stone formation, you need to make a graded plan in the OT where you go from one procedure to another in the same anesthesia. कि पहले ये किया बाहर आ गए, फिर ये किया बाहर आ गए, फिर तीसरा किया, ऐसे नहीं. So this patient will not work by simple stent removal. This patient will not work by ESWL. Remember, ESWL also has a problem that many times these stones are infection stones. So there is a very, very high risk of sepsis post ESWL for neglected stents. Okay. So your plan in this patient would be, you see, there is definitely a big chunk of stone in the kidney, which probably needs removal. So first and foremost, answering what sir has asked, you need to evaluate further. You need to do a CT scan. If necessary, if the cortex is very thin, you probably need to do a nuclear scan. Once you document that this is a salvageable kidney, and I can see that there is a big stone in the kidney which needs to be removed, I will start removing the stent from above and not from below. So my plan will be to go for a PCNL, remove the upper stone, try to pull the stent out from above. If necessary, do antegrade ureteroscopy and remove the fragments. Or you could do both up and down. You have to be ready with multiple procedures in neglected stent, where if one procedure fails, you automatically move to the second procedure. You see now, this is a very, very poorly functioning kidney. The cortical thickness looks extremely poor.
That's what.
So the important things while doing neglected stent is that, remember that this is always, it comes under a complex endourological procedure. You need to keep most of your equipments ready. Means you may need rigid URS, flexible URS, PCNL, everything. You may need lithoclast, you may need laser. So you may need to keep a lot of equipments ready. You need to keep the patient's consent ready for 2-stage. You will definitely need to restent most of these patients. And then again, instruction for a timely follow-up for stent removal. A proper antibiotic cover before this procedure is important, and do maximum investigations possible so that you have all the pre-op information. Means I would do 3D reconstruction. I would do say proper 3D say orientation of the system to understand exactly where the incrustations are, where I need to make a puncture, and how to plan my procedure.
Yes, sir. Sir, nuclear scan should we do in this case, sir?
I think so. The cortex looks quite poor.
Yes.
And you know, whenever the cortex is poor, it is always better to do a baseline nuclear scan. Suppose this patient is treated by me or treated by somebody else. If it is treated by somebody else, before I take over this patient, I need to document, okay, the function was not good before I took over. Otherwise, I will do PCNL now, and 6 months later, if somebody gets a nuclear scan done, how will we show कि ये functional loss मेरे वजह से है या पहले surgery से?
Right, sir.
So baseline documentation of kidney function is extremely important. And if the cortical thickness is less than 5-6 millimeters, always get a nuclear scan done.
So Abhishek, you know, just make those guidelines that, as Dr. Pankaj mentioned, if it is less, if it is thin, even though the CT scan is showing contrast, everything excreted, still for our medico-legal purpose, because this becomes like a medico-legal. You don't know when it is, you know, he will be becoming hostile. So better to do renogram and then go ahead. If it is good functioning kidney, good parenchyma, it documented on CT, then it's okay, like any other stone. And as he said very rightly, prepare him for cystolithotrity because there will be surprises. When you go inside, suddenly the lower end might be having an encrustation, and you might have to break down those stones. Then you might have to do URS, you might have to do, and then you'll be doing PCNL. So as Dr. Pankaj Maheshwari said, these are the stents which are ideally should be removed by PCNL, because if you pull it from below, there are chances that you will damage the ureter very badly. So please understand this.
Yes.
And Abhishek, don't discuss theory when you are going for these short vivas and for the practical. You listen to the question, ask, and be precise, because then the important things will be missed. Okay,
Yes.
fine. Okay. So this is a CT scan now. Paras, what we did. So anyway, Abhishek, now final answer. So what you will tell patient and how will you proceed?
So I will explain the patient regarding the condition of the DJ stent fixed and the multitude of procedures that may be required to remove the DJ stent. And sir, in the consent also, I will take consent for PCNL and antegrade removal of the stent, as well as flexible and or rigid ureteroscopy as and when required. And also a consent for cystolithotrity and explain the patient regarding the same, and then take him off for the procedure. And under the same anesthesia, sir, I will remove the stent by I will remove the stone and the stone in the pelvis by antegrade procedure, and and then in the same this thing antegrade I will try to remove the stent, and then sir proceed accordingly, sir.
So what is your criteria for removing the kidney?
Sir, GFR less, GFR less than split function less than 10% and GFR less than 15 is
उल्टा होगा.
okay. Yes, sir.
Differential function less than 15%.
Yes.
And GFR should be some one book it is given 11. People usually take it as a 10. If it is pediatric, still try to preserve the kidney. These are different practices done by the various urologists. But if cortical thickness is paper thin cortex, if it is a bag of water, and if the differential function is less than 15%, GFR is less than 10 or 11, then preserving such type of kidney is not a good idea. So you have to explain this to the patient and go for the nephrectomy. That is one thing. If you don't want to go for the nephrectomy, you have to explain the multiple procedure, multi-stage procedure. As Pankaj sir told, you can go from above, try to break that pelvic stone, try to pull it from above, antegrade URS, retrograde URS, RIRS, everything should be ready. And if only thing when patient is in full-blown sepsis, and if there is a local gross tenderness and ultrasound suggests of suppose pyonephrosis with breach in the cortex, perinephric collection, in such situation only you have to place the PCN and stage the procedure. That is the only one condition. Otherwise, injectable antibiotics, stabilize the patient, and go for the stages what Pankaj sir and Gaurang Shah sir has explained. This should be the plan for treatment of such type of patient.
Only one small practical hint I want to give. Many times I have seen that when there is a marginal, means we are not sure whether to remove or whether to remove the kidney or to keep it. Fine. In these cases, these are the cases where there are very good chances that if you remove the DJ stent, if you control infection, if the kidney is totally clear, the kidney may start functioning little better. And in this case, when patient has got CKD, that is creatinine is raised, then better to avoid nephrectomy if possible. Otherwise, if it is indicated, go ahead.
Right.
Sir, this patient with DJ stent, if his GFR is suppose 11 and differential function is 15%, that means and the stent placement duration is 2 years. Probably this patient may have poor function before doing the procedure what that surgeon has done 2 years back since initial only. So I will interested in seeing that pre-procedure differential function and GFR. If it is already 20 and 10 at that time, now it is 15 and 11. Then and already there is a chance sepsis and multiple stones at multiple places. And global GFR, if it is near to 60, so 58.9 after removing the 11% kidney. So it is not too bad with single kidney. So
Fine.
and
So
age
we
of
can
the,
do all this. Yeah,
all the
personalization and then decide the treatment. Correct.
sir,
Fine.
your opinion.
Yeah, Paras, just tell them what we did and go for a second case.
So we did a PCNL with URS with a DJ stenting, and we have planned to do a repeat DTPA scan after 3 months.
Yeah, so we removed this and we removed all the stones and we have kept the DJ stent. We have removed it and now we are going to repeat DTPS scan. Okay, next case. So who is answering now? Ojas? Ojas is there? No, the
Yes,
Prashant
I
you
will
can
take, sir.
answer. Huh?
So I will take.
Oh, yeah. No, Prashant is there, no?
Yes.
Yes.
Yes, sir, Prashant.
Okay, Prashant, you answer. Acha, Ojas is there? Okay,
Yes, sir.
Ojas. Ojas, if you are
Yes,
there,
sir.
you. Then the next will be Prashant.
Yes, sir. I will take, sir. Yes, sir.
A 14-year-old boy presented to the emergency with left scrotal pain since evening. Pain is sudden in onset, started while playing on ground, radiating to the umbilical region, no dysuria, hematuria, fever, nausea and vomiting. On examination, abdomen is soft and non-tender. On scrotal examination, left testicular tenderness is present with pulled up scrotum and loss of domestic reflex. Past history, no surgeries or no comorbidities. Hemoglobin is 13.2. TLC is 13,400. Serum creatinine is 1. What next?
Have you taken photograph of patient's scrotum? Do you have?
No, sir.
No, okay. It was taken earlier, but next time you put it.
Yeah.
Okay, now next what?
Yes, sir. Sir, based on the history and the examination findings, this looks like more likely to be a testicular torsion. However, first I would like to make the patient comfortable, explain the explain the parents of the patient that the patient is having probably a torsion of the testes. I will give some painkillers first, then I will examine the patient. As part of the examination, I will assess the entire scrotum. I will assess the right side first and compare with the left side. I will assess the rugal folds. I will assess the penile skin, trapezial skin, and the testes. Then, while examining the testes, I would be gentle because there is more likely the patient having pain. If my clinical findings suggest that it is more likely to a torsion, I would like to do a ultrasonography of the inguinal-scrotal region with Doppler to confirm that it is a torsion testes after giving painkillers, and then proceed from there. And also inquire when the
My
pain starts.
question is, you said if you think that it is a torsion of the testes, you will ask for the ultrasonography.
Yes, sir. And also,
otherwise you will not ask.
Yes, sir. Yes, sir.
Otherwise you will not ask.
No, I will ask, sir. I will ask.
So then why you are saying that? Why that statement? And why you want to waste time? This patient has come after 5 hours. You got a telephone that at 12 o'clock he had a pain at 4:30, and now he is coming to you. What you will do?
So then I will do a bedside sonography if possible, or otherwise immediately take him to the sonography department and get a sonography Doppler done to check for the vascularity, and also inform the operation theatre that we would require an urgent exploration if it is viable testes.
So what you will do along with that?
A Doppler, sir. A Doppler along with
Doppler, but anything else you will do along with that?
So
any
can
other
attempt. I will call the operation theatre and the anesthetist that we might require an urgent scrotal exploration.
So then tell us, na, that of course this examination is very important, but you in emergency only when you are doing ultrasonography you can do the examination. Why you
Yes,
want
sir.
to waste time? You comes there. Every moment is important because this patient doesn't come within half an hour of the pain.
Yes, sir.
They might have come up after 5 hours, 5.5 hours. And if the parents are knowing that if it is a torsion, that GP might have told him, okay, 6 hours. In 6 hours, we have to save these testes. They are also
Yes,
worried.
sir.
So in the exam, when such a thing, such a case, even in practical it comes, you have to do everything at the same time. Arrange
Yes.
for
Yes.
color Doppler, arrange for sonography, do all the investigation at the same time, examine him. And if it is there, directly take him in OT. Don't
Yes, sir.
waste any time.
Yes, sir.
Pankaj bhai, you want to say something like in your emergencies when you get such cases? Gite sir, you want to say, add anything?
Sorry, I was muted.
Yeah,
I
yeah.
did not realize that I was talking. I was saying that remember that torsion diagnosis is a clinical diagnosis. You do not need sonography or Doppler to explore this patient. So if it is going to take time, do not get the investigations done. Having a negative exploration in torsion is absolutely acceptable. Means there are reports where the negative exploration rate has been as high as 30 to 40%, and even that is acceptable. So as sir was saying, every minute is important. Just get the patient prepared for OT and immediately take him for exploration.
Yes.
And a color Doppler nowadays in big cities and all we are doing just to save our skin. Doctor, what means I will agree with him. If required, if the suppose I am in a small place where the sonologist says that I will take 1 hour to come and then I will do it, and then that also not in the department means I have to send him somewhere else, and then he will come back, and again I have to arrange for OTs and all these things. I will not waste my time. Because
Yes, sir.
14 years old, no fever, okay, sudden onset, all these things in favor of torsion only. And even if it is negative, what happens?
Yes, sir.
Okay.
देखो,
Yes, sir.
sir,
Yeah, bolo.
the age of the patient is favoring towards the torsion side.
Yes, sir.
Thorough clinical examination, detailed history. That is, this patient usually present with severe unilateral pain, nausea, vomiting, fever, local condition of the testis, erythema, edema, swelling. Then affected site is comparatively higher than the non-affected site. Loss of cremastic reflux may not be the diagnostic. It is present, absent in 30% of normal patient also. That is the thing. If you clinically suspect it is acute scrotum, that the torsion, it may be torsion testis, it may be torsion appendix of the testis, it may be torsion of the cord structure, extravaginal, intravaginal. Once a torsion, if you are suspecting clinically, you have to take it as early as possible to the operation theater with prior consent for the exploration, SOS archidectomy, archidopexy, and opposite side 100% archidopexy. This all things should be explained to the patient. Intraoperatively, you have to check, detort it, check the color, and if it is completely darkened, you have to take the photograph, show to the relatives it is completely blackened, send it to the histopathology, because removing the testis is not legally it is very important. जो भी है आपका पूरा परफेक्ट रिकॉर्ड रहना चाहिए एंड अपोजिट टेस्ट को फिक्स करना चाहिए. These all things should keep in mind. And exploration with or without Doppler. Doppler is not compulsory, as Pankaj sir has told. Clinical examination is basics in diagnosis of torsion testis.
Yes.
Just show what we did and we'll go ahead.
So we directly took the patient to the sonography where the radiologist was available. On color Doppler, was a diminished flow in the left testis with minimal fluid collection with heterogeneous patchy changes in the testicular parenchyma with a bulky epididymis. We took the patient to OT for scrotal exploration. These are the intra picture. There is an intravaginal torsion of the left testis. We just kept the we just derotated the testis and the color revert back. We did left bilateral orthidopexy.
Then don't say anything. Okay. So
Yes, sir.
what you will do now?
Yes, sir. So since as you can see initially, yes, there is huge discoloration, and we can see that there is torsion at the level of the cord structure. So after detorsion, since the color has changed, we will explain, we'll convey that during the surgery, or it has to be conveyed to the relatives that this testis is salvageable, and we will like to go ahead with orchidopexy for this side as well as the opposite side. So we will do a bilateral orchidopexy.
Okay,
3
Ojat,
point.
I want to ask you one question. Once you
Yes, sir.
open it up,
Yes, sir.
okay, and it is bluish in color, what you will do?
Yes, sir. So if it is bluish in colors, I will first try for detorsion. After, and I will also check for pinpoint bleeding. So if there is bleeding and after detorsion the color changes, so we'll wait. We'll wait after detortion if the color changes. If it is completely black and necrotic, then we have to go with ocherectomy. If after detortion the color changes and becomes red, as you can see in the right hand side of the image, it becomes as the color has changed, then we can the
No,
testis
beta, I
salvageable.
want to know to improve the circulation. What are the steps you will take?
Yeah, so we wrap it with warm saline gauze. Detortion, wrap it with warm saline gauze. Ask the anesthetist to give increase the oxygen
100%. Okay.
100%. Yes, sir. And warm saline gauze, and this will be it. So detortion, warm saline gauze, placing a mop around it, and increasing the oxygen saturation, oxygen supply 100%. Make it 100% O2.
Anything else you can do? Any injection?
Injection, sir, I don't know, sir.
What about papaverine?
Papaverine can cause local vasodilatation. Papaverine can be used. Yes, sir. Papaverine can be used.
So some people also advocate to inject papaverine in the cord.
Okay, sir.
You know. So Dr. Gite, what you do in such cases? Do you give papaverine or you don't give?
Usually, sir, I have not given it once also, but applying the pads, warm saline, 100% oxygen, and sometimes taking a small incision over the tunica. If it bleeds, then that is again a contradictory point, but that I usually do. Even I have doubt after applying the thing, doing this all conservative measures, and if it is bleeding only, then I will try to conserve it. Otherwise, if it is frank black or there is no any improvement, then we have to remove it. Practical 2-3 questions, minimum rotation and maximum rotation, how much it is. If you diagnose clinically torsion, then you want to detort before going for surgery. Second question. Third question is detorsion from which side to which side. So superior to inferior, lateral to medial, or something else. So these are the 3 questions Ojas can answer.
Yes, sir. So the last question is for the right side. We have to rotate it from medial to lateral. Whereas for the left side, so right side is clockwise. Left side it is anti-clockwise.
Why?
So it is. Yes, so right side will be clockwise and left side will be anti-clockwise.
Why?
So because of the direction of the head of the epidermis, that's the way it the invagination happens, sir.
Epididymis is usually at the posterior.
Yes, sir.
On both sides. So एक तरफ anterior एक तरफ posterior ऐसा कुछ है क्या?
No, sir.
तो फिर एक साइड को लेफ्ट टू राइट एंड एक साइड को राइट टू लेफ्ट ऐसा क्यों करेंगे?
So because the right side testis normally will torsion will be in the anti-clockwise direction, and the left side it is the opposite. So that's why we have to rotate in the opposite direction. So right side for detorsion it is clockwise, and left side it is anti-clockwise.
I don't think so. Because I don't know about the rest of the senior people may guide, but it is usually on the torsion is on the same way like right and left. Minimum torsion is 90 degree and maximum torsion is 720 degree. And the detorsion should be medial to lateral. If patient clinical condition and tolerate if the clinical patient presented to you within a short duration of the period, or if the patient is tolerating the pain, then it is better to detort before taking for surgery, because the surgery time taking to surgery and starting the surgery 1 hour 2 hour 1 hour तो लगी जाएगा. तो पॉसिबल है, और पेन अगर नहीं हो रहा है और वो टॉलरेट कर रहा है तो डिटॉर्ट करना चाहिए. These are my opinion. बाकी पंकज सर बोलिए सर.
Classical teaching is that the torsion happens in the medial direction, so you have to detorse laterally. But then this does not hold true in all patients. In 1/3 patients, the torsion can be in reverse direction also. The attempt at manual or non-surgical detortion should be very gradual. A single simple attempt. If child tolerates, go ahead. If not, then you would be exploring the patient.
Yes.
So means externally managing to detorse the testes, I have never succeeded in it.
No, yes, it is so painful. Means he will not allow you to touch also. So
True.
yeah, maybe under anesthesia. But then if you are giving anesthesia, why not to explore and just finish it off?
Sir, last 20 years I am able to salvage only 3 patients.
Yeah, I agree with you, because that's what I'm saying. So that is what the message I want to give to all the students, that it is the emergency where the time is very important. So don't waste time. And as Dr. Pankaj said, if the sonography and everything is going to take time, don't waste it. Take them. Negative exploration is acceptable. Only thing is you explain to the patient before doing it, and then just go ahead. So what we will do to the opposite side?
Opposite side also we will do a rhockedopexy.
So how will you do it?
Sir, for the exploration, I will take a midline scrotal incision. So after dealing with the left hand side, on the right hand side, I'll open the right scrotal sac, open the external spermatic fascia, cremastic fascia, internal spermatic fascia, open the tunica vaginalis, and then take 3-point fixation, that is medial pole, lateral pole, and the inferior pole, and with a Prolene stitch, Prolene 40. And that is a delayed absorbable stitch, 3-point fixation to the tunica albuginea, as in going through the parenchyma, the tunica albuginea to the scrotal walls. From the inside.
Only one small thing I want to tell you, that I have seen sometime, while taking the third, that bottom stitch, you should not be very low, because you may go to the tail of your epidermis.
Tail of the, okay.
So I normally, after 1 or 2 incidents, I have decided to take 2 lateral stitches. But yes, books are mentioning 3 places. But this is a caution. Fine. Any other question, Gite sir?
Why he want to do archdopexy on opposite side?
Sir, because in the case of there is the high chances that the opposite side testis will also undergo torsion because of the there is bell clapper deformity usually seen on the opposite side as well. So because of which the testis has a higher chances of rotation, sir.
What is bell clapper deformity?
Bell clapper. High invagination.
High insertion of the
high insertion of the
tunica vaginalis.
Tunica vaginalis.
So what happened? If it is high insertion, then it should be held tightly. Why it should rotate? As per you, if it is high insertion, it should not rotate.
It forms gives an axis so that it can rotate around it, because the no sir.
The mesentery of the cord structure is lax, and when tunica vaginalis completely surrounds the testis, epididymis, and part of the spermatic cord. Laxity of the mesentery and covering all around testis, epididymis, and spermatic cord, which will cause the torsion. तो टॉर्शन होने के लिए उसको ये तो थोड़ा क्या बोलते उसको लैक्सिटी तो रहना चाहिए ना घूमने के लिए। अगर एकदम टाइट है तो क्यों घूमेगा वो? हाई फ्रूनिलम है समझो और लो है तो उसमें लैक्सिटी तो रहना चाहिए ना मेजेंट्री का, तभी घूमेगा, नहीं तो नहीं घूमेगा ना।
Okay.
So tunica vaginalis when completely surrounds the testis, epididymis and spermatic cord predisposes to the torsion.
Yes.
You are understanding what
Yes, sir.
is the
Yes, sir.
answer? If it is a high means what? When the tunica vaginalis is incompletely, means it has to get obliterated. Okay, very
Yes,
near
sir.
to the epididymis.
Another thing is using
But
the
if-
proline for fixation. Some examiner may not agree because proline is a non-absorbable suture, and in child as well as adult, it may form sinus, fistulas, granulomas. It may be painful for palpation. It will come out through the skin. A number of problems. So your aim is to just make that testis adhered to the scrotal wall, which can be possible by doing just the jawbulge repair or lord plication, which will work like a 3-point fixation, same way like a 3-point fixation. And if you still want to do on opposite side, that's what I'm telling. And if on torsion side, you have to take a 3-point fixation with Vicryl. It is the resolution of Vicryl usually needs 90 days, and 90 days is sufficient for to have adhesions to the scrotal wall.
Fine. Okay. Paras, next case. Prashant.
Yes, sir.
So a 22-year-old gentleman underwent a road traffic accident due to slippage of two-wheeler. Presented to us in emergency. There is no sign of head injury. On examination, airway is intact. Breathing and ventilation, respiratory rate is 18 per minute. Saturation is 98% on room air. Circulation and blood pressure. Blood pressure is 118/58. Pulse rate is 100 per minute. USG fast shows right hepatorenal collection with perinephric collection. Chest X-ray and pelvic X-ray, no abnormality detected. The GCS is 15 with no neurological deficit. For abdomen examination, there is tenderness in the right flank. Genitalias are normal, no meatal bleed or palpable blood lump. Patient passed urine spontaneously. There is no hematuria.
Hello. Hello. Hello.
Prashant, what you will do now?
Yes, sir. Sir, this is a this is a case of road traffic accident with patient is having right renal tenderness. Sir, it is. I'm thinking there is a renal injury. So I will firstly, sir, start him IV fluids and send the blood investigation in the form of CBC and serum creatinine, sir. And if serum creatinine is in the normal range, I will go for the CT scan of the contrast and CT scan of the abdominal pelvis.
Okay. Show him.
Mm. Sir, this is a contrast and CT scan of the abdomen and pelvis. Sir, left side kidney is normal with size and size. With good enhancement and cortical thickness. Right side, sir, kidney is well enhancing, but the lower pole is not enhancing, sir, on right side. There is no obvious collection around the right kidney. Hello.
So what's the grade?
Sir, as there is no enhancement of the lower pole, sir, I think it's a vascular injury. I think it is a, sir, grade 4 renal injury, sir.
Can you see the accessory which is blocked? lower polar?
Yes, sir. Yes, sir. Sir, that might be the cause for the unenhancement of the lower pole, sir.
So now what you will do?
Sir, as my patient is vitally stable, sir. I would like to do. I will go for the intervention radiology, sir, and I like to see for the. I like to do stenting for the thrombosed vessel or damaged vessel, sir. Hello.
Okay. No, we are listening.
Yes, sir.
So the answer should not be that I want to do say stenting. The answer should be I want to do a angiography and see whether stenting
Angiography.
is possible.
Yes, yes, sir.
Okay, so the aim is to do an angiography and see whether there is a lesion which is amenable to endovascular intervention.
Yes, sir.
Because suppose there is, if you do a and there is a leakage, what you will do?
Sir, leakage from the vessel or extravasation from the cortex,
Answer
sir,
both.
or means PC system.
Both. Answer both.
Sir, if there is a extravasation from the PC system, not in this case, sir. If there is extravasation of the PC system and patient is stable, I would like to conserve this patient. If the perinephric collection is and follow up this patient in the form of vitals and CBC and creatinine. If patient is getting unstable, then I will explore the patient and see for the repair the pelvic LSL system and the drain perinephric connection and put the drain.
Fine. So we have conserved this patient, and now
Yes,
how will you follow up?
Sir, I will follow up this patient after. I will firstly, sir, I will tell the some precautionary thing to the patient as the patient is having renal injury. I will tell him about the avoiding the strenuous activity and bed rest for like 14 days. And after 14 days, I will follow up him with the ultrasound, CBC and serum creatinine, sir, and see for the any collection or any collection and either any deterioration in the lab values.
Okay, this patient came after 1 month with pain in abdomen, in the upper abdomen, in the
Yes,
right
sir.
hypogastric mainly region.
Yes,
Okay,
sir.
vomiting. He had a fever. Don't show. What you will do?
Sir, firstly, I will blood
What is your
investigation in the
diagnosis?
form. Sir, as patient was having non-enhancement of the lower pole. Sir, patient is having, sir, at present patient might have the infection of the lower pole and he has septicemia.
Okay. So what you will do now?
Sir, I will firstly stabilize the patient in the form of I will start the IV fluids, antibiotics, do the CBC and serum creatinine, and proceed with the I will do contrast enhanced CT scan of abdomen pelvis to look for the collection, whether there is a collection around the kidney or sir.
Yeah.
I will,
Okay. Sure. Paras,
yes.
do you have blood investigation? No. Okay. This is CCT. Prashant, you are doing well till now. Just tell us.
Yes, sir. Yes, sir.
What are you seeing? What about right kidney? It is same or it is changed?
Paras, पिछला वाला sir, it is less, sir. Like the amount of the enhancement which patient has previously, the enhancement is
So basically,
more
he has
on
not
the.
deteriorated.
Yes, sir. Yes, sir.
Then what else you are finding? See first, next to the kidney, first 3, 4th and 5th. Just see.
Yes, sir. Sir, there is a perinephric.
Is there a perinephric?
No, sir. The liver, sir, around the liver.
And paracolic, na? Below
Yes,
the
sir.
liver
Yes.
and paracolic. See?
Yes, sir. Paracolic gutter, there is collection is there. I
And
think.
below that, what you can see? Just show the marker little on the left hand side, paras. Just just about little. Yeah. What is that? What type of structure you will get like this?
Probably a pseudoaneurysm.
No, it is appendicitis, which is perforated paracolic.
Acha.
Okay.
Yes, sir. Sir, is it because of the trauma or it is just a
No. Just after 1 month. So we got a little confused because of all these things. We thought, as you said very rightly, it was suspected either the bleeding has come, it has increased and it has got perinephric abscess formation. We were also suspecting the same thing. So that is why 6 ECT was asked. We had explained. Suppose there is an infection. It is not appendicitis. If it is an infection of the lower pole, what will do?
I will try to manage this patient with the higher antibiotics.
Okay.
And see for the response.
If there is a perinephric
for the
collection, you may drain it. Correct. And if there is a urinoma formation, then you might put a digestant also.
Yes, sir. Yes.
And if required, you may go ahead with because after 1 month also, if it is a not revascularized or it has not
subsiding,
improved, then you can do partial nephrectomy. Fine. Gite sir, Maheshwari, you want to ask anything? Dr. Hudedar, your view on this, anything? Okay, fine.
So this is a really interesting case where which shows that we need to be aware about other diagnosis. Means, many times patient presenting with right ureteric colic, you presume it to be colic and it could very well be appendicitis.
Yes.
So being aware that things can be different and non-urological becomes very important. I think a brilliant case.
We immediately in the night, the radiologist came and told me that, we are on the same floor. And he told me, sir, why don't you admit this patient? He has got a perforated appendix. Means I was also surprised. So the basic idea of this clinic is that only that it is exam. Yes, it is very important. We have to train you for the exam. But now after passing, you will come across cases, this type of cases. And in initial stage, if you are gone through this discussion, you can treat these patients better. That is a basic idea.
Sir, as far as exam is concerned, examination of the history, clinical examination, nowadays pendulum towards conservative treatment for all grades of the renal trauma, including grade 5, CT, CCT, then science grading of the trauma, then type of the conservative management, indication for exploration. If someone want to explore, then with loin incision or abdominal incision, and how you entered, explore the patient of renal trauma. Where is the incision someone has to take, if he or she is going through the transabdominal route, then what are the chances of nephrectomy, and how someone will diagnose or suspect the pelvic injuries. Is there any roll-up or CT scan after 72 hours? And then at the time of discharge, what investigation to be done, and at the time of follow-up, what investigation to be done. So this is the overall go through of the renal trauma and subheadings. So examiner may ask anything about this patient as per these lines.
You have covered very beautifully, and I think all the students, those now you are going to appear, they must write down whatever you have said and say the same thing in exam. Fine. Paras, go ahead. Okay, Prashant, you answer now.
Yes, sir. T34 bilateral.
A 34-year male presented with bilateral flank pain since 7 days. Pain is sudden in onset, progressive, associated with nausea and vomiting. Patient was admitted and investigated. The ultrasound shows right renal calculi of 1.5. It's 15 mm in pelvis. Left renal 2 calculi in middle and upper calyx, 8 mm and 9 mm each. Patient underwent ESWL elsewhere for the same. Now presented to us after 2 days of ESWL with severe bilateral flank pain, decreased urine output, fever and vomiting. On investigation, hemoglobin is 13.7. The counts are 17,900. Serum creatinine is 6.9. CRP is 333. What next?
Sir, 34-year-old patient with bilateral flank pain with deranged serum creatinine of 6.9, sir. He has underwent ESWL 2 years back and presented with decreased urine output. Sir, patient is in the obstructive the uropathy, maybe because of the ESWL causing steny stress and causing obstruction of the bilateral ureter. Sir, after stabilization of the patient, I will do serum potassium of this patient and simultaneously try to stabilize the patient. And I will do, sir, bilateral USG guided PCN insertion.
Wait,
Yes, sir. Yes, sir.
This patient SWL on one side.
Both sides.
Both sides.
Yes.
Yes, sir.
And only have sonography report. And ESWL in same sitting for both sides.
Yes, sir.
So this is a grave mistake someone has done. Doing a lithotripsy on sonography report and that too on both sides is a negligence.
Absolutely. So Prashant, would you have given ESWL to this patient?
Yes, sir. Hello.
Would you have given ESWL to this patient, say either right side or left side? What would be your indications of ESWL today?
Sir, I will do first CT scan of the kidney ureter bladder. CT IVP I will do, sir, first. And then I will see for the like hardness of the stone. And accordingly, sir, the location, size of the stone, I will like to plan accordingly the ESWL session for the patient.
So what do you mean hardness of the stone? मतलब क्या देख रहे हो?
So Horns unit, I would like to say whether it is a soft stone.
We will look at the Hornsfield unit. What are the
Yes,
other
sir.
things you look at in the CT scan?
Yes, sir. I will also see, sir, skin to stone disease, skin to stone distance, sir. Location of the stone, Horns unit of the stone, and the stone burden I would like to see, sir. Like size of the stone I will see, and accordingly. Yes, sir.
What is the cutoff for skin to stone distance?
Sir, it is 10 centimeters, sir. If it is more than 10 centimeter, the results are not good, sir.
Right. So a lot of literature says 9 centimeters, but yes, between 9 to 10 centimeters, it should be less than that. And how much would
Yes,
be your cutoff for HU?
Sir, it is 1000 Hounsel units.
ठीक है. So now suppose for discussion sake, let's say ये 15 millimeter जो stone है, this is 1100 HU and 9 centimeter SSD, and patient wants USWL. Will you do it?
Yes, sir. After ruling out any obstruction to the right kidney, as the stone is 1.5 centimeter and it is in the pelvis, I will do it, sir.
So USWL
5
remains one of
millimeter.
the treatment options. Yes, good. So go ahead now. Let's come back to this case.
Yes, sir.
The right
So,
side is 1.5 millimeter. Right side is 1.
It's 15 mm.
No,
15
it is
mm.
1.5
a
centimeter.
typographical error. It is 15
1.5
millimeter.
centimeter.
1.5
Yes,
centimeter.
1.5.
It is just a
Yeah.
typing error.
Prashant, why this patient
Yes,
had
sir.
a raised creatinine? What are the probable causes?
Sir, it is the like already patient might be having, sir, compromised function before the before the intervention, and after
Then again ESWL will not work in such type of patient.
yes, sir.
So we post ESWL bilateral. If his or her creatinine is 6.5, what are the probable causes?
So bilateral obstruction to the
So
both the ureters, sir.
but he has done excellent ESWL, and there is a fragmentation on both sides, and both fragment come down to the ureter, and that is blocking the ureter. That is one possibility. Another possibility.
Yes, sir.
So what else after this? So bilateral
Sir-
Stein's obstruction. What else?
It can be because of the infection, sir.
So patient may be in sepsis, both
Yes, sir.
system get involved, and
Yes, sir.
there will be residing. Any other reason?
Underlying like
Any complication by ESWL on both sides, which
yes,
causes
sir.
this?
Bilateral hematoma, subcapsular hematoma can also cause the renal damage and raise creatinine.
So parenchymal injury or renal hematoma?
Yes, sir.
Fair. Good.
So now what will you do?
Sir, like I will do plain CT scan of the patient and proceed with the bilateral PCN insertion, sir.
No. Wait, beta. Plain CT scan
Yes,
बोल
sir.
के रुक जाओ. पहले report
Yes,
तो
sir.
देख लो. हाँ.
Yes, sir. Yes, sir. Yes, sir. Bilateral I will do
Ask for a plain
non-contrast.
Yeah.
Yes,
Don't
sir. And I
plan the
will see
treatment
for
without seeing the CT.
yes, sir.
Huh.
I will see the condition of the both the kidneys and position of the stone if they are like
Paras?
Show the CT way. Good, Gita sir, what you said is right. A good ESWL has been done.
sir, this is a non-contrast CT, and we are seeing coronal film, sir. Right kidney, bilateral kidneys are normal, sir. On right side, there is multiple stone in the right mid and lower ureter, sir. And on left side, sir, upper ureter at the PU junction, sir, there is a single stone present. And
So I
yes,
have
sir.
objection to two things that you have said. You started off saying
Yes, sir.
bilateral kidney are normal. So they are not normal, they are hydronephrotic.
Yes, sir. I
Okay,
mean,
and
sir, the thickness of the bilateral
you mean parenchymal thickness
cortical
is good.
thickness.
Okay,
Yes,
there
sir.
are no hematomas. And second is,
Yes, sir.
will you call the left stone at PUJ?
See,
No, sir.
see properly, na?
Upper ureter कहोगे?
Sir, upper ureter, sir.
हाँ जी, ठीक है.
Yes.
So bilateral obstructive uropathy related to fragmented stones, multiple
Yes, sir.
fragments in the mid and lower ureter on right side, and one large
sir.
fragment in the left upper ureter.
Yes, sir.
Here you should also mention that the bladder is full.
Or distant.
Yes. Yes, sir. Blood is over distant.
Chale. So what's your plan now?
I will decompress the bilateral renal system, sir, in the form of USG guided PCN insertion.
Why? Why PCN?
Sir, as the patient's creatinine is 6.9, sir, the PCN can be inserted. Yes. PCN can be inserted it under local anesthesia under ultrasound guidance, sir. And then after. Hello. Sir. Yes, sir. Sir, drainage is better with the large bore. PCN is patient as the diameter of the PCN is large, sir. So putting PCN drainage will be better with the PCN, sir.
So you know,
and also we
really
can
never been proved that PCN is better than digestant. We presume it to be better, but there is a lot of literature which says that the results of both are nearly same, even in presence of infection. Here we just have obstructive uropathy, no obvious or significant infection. So I think you should keep the option of digestant also.
Digestant. Yes.
So if answer like this, I will try for digestant. If failed, will consider for PCN. That will be the great answer in the exam, because the digestant, the number of students digestant, we were also doing digestant under local anesthesia.
Yes.
And one important, Gite sir, one important thing is that if you put a digestant, there are chances that this ureter may be little hostile. So if you put a digestant, it will accommodate
Passive
your
dilatation.
ureteroscope later on very easily.
Passive dilatation. Yes, sir.
Yeah.
Another PCN ke liye, there is no internal echoes. Particle thickness is adequate in this patient. So chances of complication is more in the PCN. Then the PCN is not without any complication. It itself has n number of complications. PCN, peripecian leak, skin excoriation, falling of the PCN, dislodgement of the PCN, recollection. तो बहुत सारी चीजें बता सकते हैं.
So bleeding, aneurysms, everything can happen.
Yeah.
Yes.
So PCN is not answer. So
see,
in exam, as far as
you have to
this coming exam,
yeah,
you should be very alert and answer to one time to one question. जैसा पंकज सर ने बोला, एक बार इन्वेस्टिगेशन और ट्रीटमेंट एक साथ नहीं बोलना.
Yes, sir.
तो पहले इन्वेस्टिगेशन होने दो, उसका रीड करो, उसके बाद में ट्रीटमेंट डिसाइड करो.
Okay.
And every case is different. Every case you can't say hydronephrosis, you will do PCN. You understand?
Yes,
so in this case, now you have worked in your department. What routinely was done? In such cases, bilateral obstruction, patient comes with a high creatinine. What you forget about DSWM? What you would have done?
Yes, sir.
You know, think of that and say answer. You will not be wrong.
Yes, sir.
Okay, Paras, go ahead. So, Ojas, answer.
Yes, sir. Yes, sir.
So a 58-year-old gentleman, known case of adenocarcinoma prostate, had a recurrent failed catheter-free trial, presently on silicon 14 catheter. Patient has a history of radiotherapy for carcinoma prostate 1 year back and a long-term hormonal therapy in the form of LHRH agonist. On investigation, hemoglobin is 14, TLC is 14,440, creatinine is 1.2. The present PSA is 2.3. The Nadir PSA was 7 months back, it was 0.78. Urine routine microscopy, the WBC count are 80 to 100 per high power field. RBCs is 2 to 3 per high power field. Urine culture shows E. coli, sensitive to meropenem, amikacin, and colistin.
First, I would like to know whether the patient is febrile, whether he has hematuria, whether any recent investigations of PSA and any other imaging in the form of a PSMA, PET CT or anything was done. So whether this patient is febrile first, I would like to know about the patient is
No,
febrile.
patient is afebrile.
Hemodynamic is stable.
Hemodynamically stable.
Okay. When was the catheter last changed?
1 month back.
Is okay, 1 month back.
Patient is
Okay.
on catheter since 6 months.
6 months. Okay. So, sir, there is no fever. The counts are still raised. Creatinine is normal. The PSA is 2.3. Okay. So this patient is a known case of adenocarcinoma, has probably recurrence because and is probably not responding to the current androgen deprivation therapy which is taking. Because the PSA is 2.3. However, I like to know the other previous, whether there is a 0.78 and there is a 2.3. So most likely it suggests that it is going towards recurrence, though it doesn't satisfy the definition of nadir plus 2, but it more likely shows that it is has a recurrence. So first I would like to admit the patient, start him on antibiotics according to the sensitivity. Again, also send yes, sir.
Where is the recurrence?
So for that, I would like to do an imaging, sir, because the PSA is 2.3.
What treatment he has received? When it is
So
called
LHR
as,
is agonist. LHR
if,
is agonist.
if this patient is getting RTA and HT, what it suggests? Definitely it is either locally advanced or it is a metastatic disease.
Okay, I meant yes, sir.
Until and otherwise this stage, why you will give, someone will give RT plus HT. The primary RT sometimes it is possible for localized disease also. And if when the person has given HT as well as RT, then what it suggests? Why that someone has done hormonal therapy given?
So then it is more likely to be a CRP, castration resistant, but the metastatic castration resistant post prostate cancer is going towards that.
So for which stage of the CA prostate the treatment is HT plus RT? Answer this question.
So for advanced metastatic CA prostate.
Any other stage?
No,
medium
can
and
you
high
hold on,
risk.
hold on. Stop here. Why will you give radiation for advanced metastatic CA prostate?
Yeah, only for the prostate was given. Actually, yeah. Okay, not only the prostate is given, not for the bone mets. Okay. So then it was used as a.
So before answering any question, now you think twice.
Yes, sir.
कि क्या सिचुएशन है और वो क्वेश्चन वो ट्रीटमेंट क्यों दिया है, अदरवाइज क्या है कि अननेसेसरी पूरा गड़बड़ हो जाए.
So do you give radiation plus hormonal treatment for localized or localized cancer prostate? Let me make question more specific.
Yes, sir. Repeat, sir. Sorry, sir.
Will you give radiation plus hormone treatment for localized cancer prostate?
So if it is high risk, then we might give. Yes.
What do you mean high risk?
PSA more than 20, Gleason grade group 4 or 5, and percentage score of the biopsy was more than 33%.
But
Yes,
you know, the biggest thing in localized cancer prostate is the decision-making process is based on the average life expectancy of the patient.
Yes, sir.
Okay. Remember that for first 6 to 10 years, 6 to 8 years, probably the results of hormone therapy, radiation and RP are same. So unless a patient has a life expectancy of more than 10 years, only then you will advise radical prostatectomy. So although this is a young gentleman, but you do not know, maybe he had a couple of angioplasties or a recent heart attack. Okay, he's high cardiac risk. So that is why even for a localized patient, hormone therapy plus radiation is appropriate treatment. Hormone therapy is usually given with radiation because it potentiates the effect of radiation.
Yes.
And then you would, next question would be how long to give hormone therapy? That will depend on high risk and low risk patients. Hormone therapy can be from 0, 2 years, 3 years, depending on individualized case.
Yes, sir.
Okay. So this patient has received hormone therapy plus LHRH agonist 1 year. Now there is a rising PSA. So do not call it recurrence. Recurrence is not the right word here.
Okay. Yes, sir.
हाँ.
It
So
is
अभी
going towards CRPC.
Second thing, you please understand that
Yes, sir.
from the beginning, 6 months he is on a catheter. I can understand that when the PSA is rising and after nadir creatinine, I mean, this thing, PSA was so low, 0.78, that was 7 months back, and he's on a catheter since 6 months. So what is their interpretation?
Yeah, it
Can
will
it be
be.
something else also?
Yeah, it can be falsely related also, but then in this scenario, we would more likely say that it is
No. Can it be something else in the prostate also?
prostatitis or, but no, but
why not? Why
PSA
not?
bounce.
PS,
PSA bounce, sir.
What
Ojas,
is PSA bounce?
Yes,
What
sir.
is it?
why someone has placed catheter for 6 months?
patient has obstructive nuts because of the CA prostate, so that's why it
Only
probably
say
has
prostate.
So
enlarged
patient got edit hormonal treatment. Patient got radiation therapy, and patient is for 6 months on the catheter. He is avoiding LUTs. Why avoiding LUTs? Why he is not passing the urine? What is happening at the level of?
there is obstruction at the bladder outlet, or the bladder patient might be having a contractile bladder, so that could also be a reason. But apart from that, there is some obstruction definitely in the form
Why
of
a contractile bladder in
these.
CA prostate? Why unnecessary? Why you are digging
गलत
yourself?
डायरेक्शन में चले जाते हो भाई आप.
सोच के बोलो ना भाई.
Yes, sir.
So there are two chances, na? As you said that PSA is increasing, so there may be radiation has not worked, and there may be a recurrence, local recurrence, and it is causing the obstruction, or the radiation is not going to affect the normal tissue. So there may be
Yes, sir.
associated
Yes, sir. Radiation related urethra. Yes, sir. Urethral structure changes. Yes, sir. Urethritis and
urethritis, or there may be associated adenoma, na? The
yes,
benign. So
yes, sir.
that also
See,
can give rise to
one
obstruction.
simple thing: any patient who is on catheter, don't diagnose urethral stricture.
Okay.
Exactly. The stricture is out of fashion in this patient. So it can be some benign element also which is causing bladder outlet obstruction, or it is the malignancy which is causing obstruction. So what will do in this case?
So first, I would like to do an imaging. So I would like to do, if facility available, then I will go ahead with a PSMA PET CT scan, or I will go ahead with a CT abdomen plus pelvis plain plus IV contrast to assess
Forget
the
about all
current
this.
status. But
What you
ideal
do
would
to
be
the
a PSMA
obstruction?
PET CT facility available. For the obstruction, so patient is already on a catheter. So
जैसा जैसा एग्जाम नजदीक आ रहा वैसा वैसा तुम्हारा सब लोगों का कंट्रोल जा रहा है.
Simple answer देने भाई.
जो रूटीनली तुम्हारे पास करते वही बताना यार.
बेटा obstruction है 6 महीने से is not improving. What do you like to do? You want to keep him on a permanent catheter?
we can we will start. If not started, we'll start in one
Everything
alpha blocker.
started. Alpha blocker, everything is started. Everything is failing. He is not able to pass urine. He doesn't have a contractile bladder or
Then
detrusor.
suprapubic cystoscopy, SPC could be off. SPC can be
Directly.
off.
Why? Give your reason.
So because it will decrease the chances of infection because it bypasses the lower
You don't want to do.
urethra.
You don't want to do periurethral anything, any manipulation.
What is
You want
channel
to keep him
TURP?
lifetime on a suprapubic?
So we can do channel we can do channel because patient he's not in infection right now. Yes, sir. So we can offer channel TURP. Yes, sir. We can offer channel TURP.
Why you are taking such a long time?
Yes, sir. Yes, sir. Yes, sir. We can offer channel
Will it
TURP
be
to the
easy?
patient. So, yes, sir.
Will it be easy? Will it be easy?
No, sir, because post radiation, the urethra will have some changes, and also it will. Yeah, that would be a main thing, sir, because the patient has radiotherapy, so the urethra will not. Yes, sir.
मेन थिंग क्या है, anatomical landmarks while doing the TRP is lost.
Yes, sir.
So there are more chances of having incontinence. There are more chances of having injury to the sphincter.
Yes, sir.
तो ये आंसर होना चाहिए ना.
So
Okay,
your
sir.
answer should be, I would
अगर
like to do channel TURP, but in this case, after radiation, it will be a rigid urethra. So chances are very high that I may not be able to put a large size my resectoscope. That is number one. Number two, as sir said, there are very high chances that I may not have proper landmark, and the patient may become incontinent. Okay. And the third
Yes,
thing
sir.
is there may be a recurrence in obstruction, because patient is not responding to the radiation or hormonal therapy.
Yes, sir.
So in this case, I will also offer him suprapubic.
Yes.
So now another question to you.
Yes, sir.
I want to ask you. Okay. Suppose this patient comes to you with a localized prostate cancer, but he has got a retention.
Yes, sir.
Okay. How will you
Yes.
go? Management
So,
wise.
yes, sir. So first, I will stage the disease. All the biopsies, everything is done, na, sir? Everything is done.
Everything is done. It is a proved case. It is a
was
localized
was
old man.
सर ने वर्ड यूज किया है localized
Yes,
prostate
sir.
cancer.
Yeah,
उसमें
yes, sir.
सब आ
Yes, sir.
गया.
Sorry. Yes,
And
sir.
he's an old man, and you are not
Ah.
going to do radical prostatectomy. You are going to you decided to give him radiation. Now, how will you go about?
And hormonal therapy has he received, sir, or has he been hormonal therapy has been offered, na, sir, or bilateral oculectomy has been offered for the patient? Initially, would be a management. Offer bilateral oculectomy, start him on alpha blockers, and then see whether if it improves and responds. If it doesn't, then he might require a channel TRP in the later front. So initially would be a androgen depression therapy, either in the form of bilateral oculectomy, that is surgical castration, or medical castration, and along with starting an alpha blocker, and then reassess if he's improving. Okay, otherwise he can be offered a channel TRP in follow-up period, not in the immediate setting.
So localized prostate cancer, you want to do a surgical castration.
You see, just never offer orchiectomy for localized disease.
Moses, I will not forgive.
Yes, sir. No, localized. I'm sorry.
So temporary orchidectomy you want to find out whether this patient will improve after radiation, or he should undergo TURP. There may be element of benign part. So first you give hormonal therapy. So you do medical castration. You wait for 1 month. Usually within 6 weeks, the obstruction will be relieved. If the obstruction is relieved, he is passing urine, just give radiation. If he is not, then do channel TURP, and then later on you give radiation.
No, sir. Sir,
Yeah.
आपने जो situation दिया है, localized prostate cancer, not willing for RRP.
Yes.
If I am not wrong.
Correct.
So with catheter.
Yeah, he is on a catheter.
So
Catheter-free
here
trial
the
has
prostate.
failed. Catheter-free trial has failed. We are deciding for the radical radiotherapy.
So radical radiotherapy is a plan of treatment, and if you want to remove the catheter.
Yes.
This is the situation. अभी सोच के बताओ क्या करें. पेशेंट ओल्ड एज है, आरआरपी नहीं करना है, रेडिएशन चूज किया है और कैथेटर पे है.
Then we'll follow him up, sir. Then whether the
तो बिना सोचे मेडिकल कैस्ट्रेशन सर्जिकल कैस्ट्रेशन क्यों बोल लिया?
Yes, sir. Just follow him up, give alpha blocker, give a catheter-free trial, and see if he voids. And also, we'll be monitoring the PSA levels. And
you want to give only RT, or you want to add HT in this patient?
Sir, if it's
it is localized prostate cancer.
Localized, no, sir. So no hormonal therapy. No hormonal therapy.
Okay. So there is no
Oh,
question
okay.
of hormonal therapy. Then you want to remove the catheter. How will you remove the catheter?
So we'll start him on alpha blocker, follow him up, give a catheter-free trial, and then see.
Suppose it is fat.
Uh, then, uh, then in that case, he will be offered a channel TRP.
Agreed. Any other opinion, Pankaj sir?
Yes, sir, that's absolutely good.
Yeah, but at the same time, once you give the one shot of hormonal therapy, and if the patient improves and he passes urine, then we don't have to do channel TRP. Otherwise, you go ahead, do the channel TRP and give radiation therapy.
Sir, practically you are right, but theoretically localized prostate cancer के लिए हार्मोनल थेरेपी का कोई रोल नहीं.
No, that is single dose. With that, it can shrink.
I have not come up.
Like like for example, if it is advanced, even if the metastatic and the patient has got obstruction in the CA prostate, so we don't do TRP. So first we give
Agreed.
hormonal therapy. If he improves, then we don't do TRP. If he doesn't improve, we do channel TRP.
In such situation, I agree with you. When the patient had an indication for giving the HT, and if you are planning to give HT either medical or surgical way, then there are chances of relieving the mechanical obstruction caused by prostate by 50%.
Yeah.
And requirement of surgery is there in only remaining 50%. But here, there is a ideal no any indication for giving the HT.
Yes. See,
Practically, KM people, madam also trying calutide for reducing the size of the prostate. Then going, few people will do anti-androgen therapy. But giving a single dose anti-androgen therapy may not help in such situations. Surgical castration is a complete castration, irreversible castration, and that's why it will work in reducing the size of the prostate as well as successful result of the relieving of the obstruction in 50% of the cases.
fine. So anyway, the moral of this question is that important thing is if you want to do surgery, do before radiation therapy. That is the moral. Means you must do channel TRP if possible before the radiation.
Agreed. Because post
If you do
radiation,
it after radiation, it will be difficult.
agreed. There is a stiffness of the urethra, then lumen will be get narrowed, and reaching to the prostate may be difficult. Patient may have complication like prostate proctitis, urethritis, fistulas, and a number of problems of radiation. So better to go ahead with to relieve the obstruction pre-radiation.
Right. Okay.
Provided that you are not going for brachytherapy.
Correct.
Yes.
Fine. Paras, next case. Abhishek answering?
Yes, sir.
Yeah.
A 18-year-old boy presented to us with on and off dull aching pain in the right flank since 1 year. Pain is non-radiating, non-aggravating factor, no aggravating or relieving factor, no recurrent UTI, no hematuria. On investigation, no abnormality, on examination, no abnormality detected. Investigation, blood and urine are within normal limit. Ultrasonography is suggestive of right kidney 11.4 into 5 centimeter with mild HUN with ballooning of the renal pelvis. Rest within normal limit. What next?
Yes, sir. So, sir, in this case, sir, 18-year-old boy, often on dull aching pain, right flank 1 year. Pain is non-radiating, non-aggravating, and sir, on ultrasound, blood and urine investigation are within normal limits, assuming creat is also normal, sir. Ultrasound is suggestive of mild hydrourotonephrosis with ballooning of pelvis. So, sir, in this case, I would want to further evaluate the condition by doing a contrast and CT scan, sir. And yes, sir, contrast and CT scan, and then, sir, accordingly, I will proceed.
This is the contrast enhancing.
क्रिएटिनिन क्या था क्या?
Yes, sir, normal.
Normal बोला,
Blood
sir.
test are normal.
Okay.
So, sir, yes, sir. So on the contrast and CT scan, sir, there is obvious hydronephrosis seen on the right side, and there is also cortical thinning seen on the right side, sir. The left side appears normal, sir, with adequate parenchymal thickness, and
Abhishek, complete right side first.
yes, sir. So
See all films.
yes, sir. So I also want to see the sir drainage films also, and in given films, sir, given films, sir, this is a corticomedullary phase that I can see. There's obvious hydronephrosis, sir, and thinning of.
See first row.
Yes, sir.
First row carefully. Then third row carefully. See everything. What about pelvis? What about ureter? What about arteries, veins, parenchyma, calyces, thinning? He is moving that marker over that particular point. Yes, now it's settled there. ठीक है, बोलो, तुमको जो जितना समझते हो उतना बोलो.
Sir, I can make out, sir, on the right side there is a cortical thinning and, sir, hydronephrosis that I can make out, sir. And there is yes, sir, there is slight enlargement of the right.
Is there hydropelvis? Is there
Yes, sir, there
external
is.
pelvis?
Yes, sir, there
Is there two renal arteries? Is the cortex is maintained in the upper and lower mid pole?
Yes, sir. Sir, there are two arteries. I'm not sure actually, sir, whether it is two arteries or, sir, the part of the.
He's seeing by showing by marker, na?
Yes, sir. I mean, sir, because I'm not sure, because this that marker where it is, sir, is it the medial border of the kidney or artery, sir? I can't make out, sir, exactly.
aorta को देखो.
Yes, sir.
वहां से क्या क्या बाहर आता देखो. सेम पिक्चर में.
Yes, sir.
ठीक है, leave it. बोलो.
Yes, sir. And so the pelvis appears to be intrarenal, sir, and there is hydropelvis.
So upper row, third film. There is aorta, there is IVC, there is exactly reaching near to IVC, there is a pelvis, parenchyma is all around, there are two vessels arising from the aorta. सब दिख रहा है, वो मार्कर में रखा है उसने, वही पिक्चर पे मार्कर.
Yes, sir.
क्लियर कर दिखता है, उसमें कोई कंफ्यूजन नहीं.
Okay, sir.
ठीक है, बोलो.
So yes, sir. So moderate right hydronephrosis caliectasis is seen associated with non-visualization or purification of entire ureter and delayed excretion from right kidney. Finding suggestive of PUJ obstruction, yes, sir. And an accessory renal artery supplying the inferior pole of the right kidney is noted abutting the dilated pelvic calyceal system inferiorly. So yes, sir, this appears to be a case of right-sided PUJ obstruction in an 18-year-old male. Sir, I would since there is parenchymal thinning and all, sir, I would like to assess the function of the right kidney, sir. So yes, sir, on this. Yes, sir. On the renal scan, sir, there is obvious retention of tracer seen on the right side, sir, and as compared to the left side. And
So fine.
yes,
Is a one
yes, sir.
round. What we will do now?
Yes, sir. So, sir, baseline function of the kidney we will assess, sir, and after sir assessment of baseline function, sir, we will explain the patient regarding the findings of the nuclear scan and the CT scan, sir, and then we will proceed to manage this case, sir. We'll give options of reconstructive surgery to the patient, and
What type of reconstructive?
sir, pyeloplasty, sir. We'll offer
Which
pyeloplasty.
pyeloplasty?
Sir, pyeloplasty, sir. This is an intrarenal pelvis, sir. So, um, sir, intrarenal pelvis, sir, pyeloplasty will be difficult. So we will explain the patient regarding
See in
either,
CT scan. Do you think it is really absolutely intrarenal?
sir, half of it is hydronephrotic, but extrarenal, sir. Matlab, on axial cut, sir, it appears hydronephrotic, and that may be because of the Puget obstruction, sir. But on the coronal scans,
You see the topmost third. You see the topmost third and fourth. See topmost third and fourth.
yes, sir.
See,
So,
it is not so much intrarenal, even though the impression is getting.
so yes, sir, I will explain this condition to the patient and then attempt a dismembered pyeloplasty in this
What
patient.
extra you will do?
Sir.
What you will do to the crossing vessel? You will leave it like that only?
No, sir. It's a dismembered pyeloplasty, sir. Sir, probably the Puget obstruction is because of the crossing vessel only, sir.
So what you will do? You will
अभी से
sacrifice it?
फ्यूज ऑब्स्ट्रक्शन क्रॉसिंग वेसल से कंट्रोवर्शियल पॉइंट है, क्यों उधर घुसना है? सीधा सीधा बोल दो ना, मैं डिसमेंबर्ड पाइलोप्लास्टी करूंगा और
yes, sir.
वेसल के ऊपर कर दूंगा. वेसल
yes,
के
The vessel will go behind.
Behind, yes, sir.
खुद में कंफ्यूजन क्यों रखना है?
See, we did robotic. Can you see the vein?
Yes, sir.
And artery
Yes.
crossing over?
Yes, sir.
Okay, so we did dismember and we anastomosed the ureter and pelvis above the artery. See, straightforward. Don't go round, round the bush. Give a straightforward answer. It is so straightforward case. Understood?
Right, sir.
Right. Okay. Last case. It's over, Paras.
Two cases are.
Want to do it? We'll finish it. Short.
Yes.
Yeah, Paras. Quick. Okay.
A 34-year-old gentleman presented with progressively increasing right scrotal swelling since 3 months. Swelling is associated with dull aching pain. On examination, right firm to hard testis palpable with inflammatory changes in the scrotum. Non-tender with variegated consistency. There is no transilluminancy. Investigation, hemoglobin is 15.1, TLC is 10,800. On sonography of scrotum, right testis measured 10 into 6 into 8 centimeter with complete loss of anatomy, with non-visualization of epididymis, with increased blood supply. This is the examination. What
Okay.
next?
Sir, 34-year-old male patient with swelling on right hemiscrotum since 3 months, sir. On ultrasound, sir, there is enlargement of testes of 10 by 6 by 8 centimeters. So my DD will be, sir, first DD will be, sir, C8 testicular mass, sir, malignant testicular mass. Hello. Hello.
Yeah, tell us.
Hello.
We are listening.
Yes, sir. Then an ultrasound suggestive of, so I will proceed with the tumor marker for CA testis.
Paras, show him all the investigations and tell us, let us ask him.
Alpha fetoprotein was 4.09, beta HCG is 66, LDH is 456. A CT abdomen pelvis was also done, which was suggestive of right testicular neoplasm, a large large homogeneously enhancing mass lesion of right testis with dilated vessel, with few sub-centimeter discrete enhancing non-necrotic lymph node in the para-aortic and paracaval region. Few small lymph nodes are also seen in the bilateral inguinal region.
Hello.
या तू बोल ना, हम लोग सुनते हैं.
Yes, sir. Yes, sir. The beta HCG level, LDH level is markedly high, sir. Alpha fetoprotein is not raised, sir, and beta HCG is marginally raised, sir. And there is also multiple lymph nodes present in the para-aortic and aortocaval region. So my diagnosis is, sir, CA testis. So I will proceed with the right high inguinal archodectomy, sir. Hello.
Yeah.
Hello.
Just see.
Yes, sir. Before that, I would like to ask about the marital status, whether family is completed or not, and if the family is not completed, I will do like semen analysis and give option of cryopreservation to the patients before going
Fine.
for the high inguinal archodectomy.
The patient has 2 child with family is complete, so we did a high inguinal orchidectomy.
Yes, sir.
The biopsy.
Sir, yeah. This is the cut biwall. This is a cut specimen of the testes showing the homogeneous mass on the lower in the cut section of the testes. I would like to see the histopathological report
Yeah,
of the
sure.
patient.
So the histopathology was suggestive of germ cell tumor seminoma with PT2NX-MX. The spermatic cord margin and was not involved. Lymphovascular invasion was present.
Okay, sir, I would like to ask about the involvement of reti testis, sir.
It was there or not there?
Hello, Paras.
There is an involvement of reti testis, PT2.
Yeah. Okay. PT2. So yes, sir. Sir, I also like to do metastatic workup of this patient.
Already done.
as
CT scan is already done.
Sir, chest was not done, sir. It is, I think,
Okay, so
abdomen
you
and pelvis.
complete with the chest. Okay, fine.
Yes, sir. CT chest I will do, sir, and I'll also do after 3 weeks of the orchidectomy. I'd like to do the serum tumor marker, sir. I'll see whether they are they are coming down or not, and proceed with the staging, sir. If they are not raised, I will stage this patient in the form of stage 1. Stage 1 high risk patient, sir, as the tumor is more than 4 centimeter and reti testis is involved. So I will advise him the radiotherapy for the lymph nodes, sir.
Show the markers after 3 weeks.
Patient still has to come for follow-up.
Okay.
Okay, sir.
Okay. I think we finish here.
Which
We
stage
stop
it is?
here. Huh?
Yes, sir.
Which stage seminoma it is?
Sir, stage 2, sir. Stage 2A.
So what are the
As
treatment
the lymph
options
node, sir.
available?
Sir, stage 2 है sir, is the radiotherapy to the dog leg radiotherapy to the uh, para-aortic and aortic wall region, sir. And if the
Okay.
lymph nodes are more than 3 centimeter or serum tumor markers are raised, so we can go for the bleomycin etoposide and cisplatin chemotherapy.
So if it is a stage 2C/3, then it is chemo.
Yes, sir.
If it is stage
Yes, sir.
2B, it is GBRT.
Yes, sir.
Okay.
So want to do the last case, sir?
ऐसा है सर, आपके हिसाब 10 मिनट का है तो करना
Yeah,
है तो करेंगे।
chalo last case करके we'll finish it off.
Yes, sir.
पंकज सर को नींद आ रही है सर।
मेरा सीवियर नेटलाइट शुरू हो गया, मेरी जरा आंखें बंद हो रही
I
है।
know, I know, I know.
I'll take your leave, sir.
Okay, 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 Pankaj. Thank you very much.
गुड नाइट।
Good
Thank
night.
you, sir.
Thank you, sir.
Thank you, sir. Good night, sir.
Best of
No,
luck,
no, no, we
everybody.
are finishing this case. Okay, fast.
Yes, sir. Pankaj, sir.
A 35-year-old lady underwent her second kidney transplant. First was done at the age of 15 years. Procedure was uneventful. Post-op uneventful. Foley catheter was removed on post-op day 5. Drain output was 20 ml each for first 2 post-op day, but from the post-op day 3rd, the drain output started increasing, and at present it is about 350 to 400 ml per day. Today is post-op day 9. Patient is maintaining urine output of 2 to 2.5 liter. On examination, there is no abnormality detected. Stitch line is healthy. The post-op day 9 serum creatinine is 1.3. Hemoglobin is 10.8. TLC is 9900. What next?
Okay.
Color of the drain. Color of the
drain is amber color.
Okay.
Fatapat answer.
Yes, sir. Initially, sir, we will like to monitor the drain output. So it is the urine output is maintained. The also the creat
Beta,
is
what
one.
you will do in Fatapat is a board round in. You have got
Yes, sir.
5 minutes to answer. What you will do in this case?
So we have serum creat. I will also seen the send the drain fluid creat level. I will do a local Doppler of the kidney and assess the kidney as well. Also,
Why you want to do local? Why you want to do
as
local?
part of the routine protocol at our patient, not just for the drains, as part of routine protocols.
Anyway, within 48 hours people are doing, but every 9 day, 10 day we don't do. When the creatinine is normal, patient is clinically absolutely fine, only the drain is high, what you will do?
And
There is no collection. Someone is asking about collection. If you do sonography, it is going to show some collection outside. But if there is no palpable mass, there is no tenderness, nothing is there, fine, 400 cc of fluid is coming out. What is the meaning of that?
So probably this is the drain has started increasing after the patient has been mobilized. So this was just a collected which has come out. So we will like to monitor the drain in the further
Last
days.
3 days it is consistently, listen, last 3 days consistently it is 350 to 400 cc. What is the meaning of that?
I will send drain fluid. Yes, sir.
I'm requesting everybody, please listen the question, think for 5 seconds, 10 seconds, consolidate yourself what to answer, decide and then answer. एग्जाम में एक बार फंस गया ना तो निकालना बहुत मुश्किल हो जाएगा।
Yes, sir.
अर्जेंसी कोई नहीं है कि सामने से
Yeah.
आया कि आंसर करना जरूरी नहीं।
Now, I am asking you a simple question. Last 3 days, his your drain output is 350 to 400. So it is constant. In which condition you will get a
Yes, sir.
constant?
Lymphoria,
The
sir.
first
Lymphoria.
question come to me is why from which place that collection is coming. So from which place it will come? It will come through the
Lymphatic.
ureter. It will come through the ureter. It will come through the lymphatic. इससे अलावा और कुछ कलर तो पता है, इससे अलावा दूसरा कोई रहेगा क्या? 9th पोस्ट ऑपरेटिव को रेसिडुअल एब्डोमिनल फ्लूइड क्यों रहेगा 9th पोस्ट ऑप को, और परसिस्टेंटली 3 दिन क्यों आएगा? सो दो ही पॉसिबिलिटी, एक तो लिम्फ रहेगा, नहीं तो फिर यूरिन रहेगा।
यूरिन
इससे बाहर कुछ होने का चांस है क्या?
नो सर।
तो फर्स्ट तुमने आंसर जो किया था फ्लूइड क्रिएटिनिन, दैट इज परफेक्टली ओके. चेक द फ्लूइड क्रिएटिनिन.
So my question is, you will ask for only fluid creatinine, or
Serum
you will ask
creatinine,
for
fluid
something
creatinine,
else?
and urine creatinine. Serum, urine, and drain fluid creatinine, all three at the same
Exactly.
time. Yes.
Fine. So fluid
What
and
will be the ratio to diagnose it
Yes,
as
sir.
urine? What will
Sir,
be
if
the ratio?
if the drain fluid creat is 10 times more than the serum creat, it is diagnostic of that it is a urine leak. And if the urine creat is
N
3
number
times,
of books. N number of books gives n number of ratios. 1:3, 1:5, 1:10, 3 times, 5 times, 10 times. But at least it should be more than twice.
yes, sir.
Theoretically, if you are answering 10 times, it is perfect.
Yes, sir.
so I will put it in a little different way. If the fluid creatinine and serum creatinine is same, it is only a lymphatic.
Yes, sir.
If it is like 10 times and more, it is pure urine.
Yes, sir.
And if it is less than 10, but more than like 1 or
It can
2,
be a mixture of both.
it is a mixture.
Yes, sir.
I agree.
So now if it, again, another thing is, if it is a constant, if you see constant 350, 400, it is 1 lakh, the lymphatic. Okay. So usually if you are a little worried, don't get worried. If it is a constant, first thing that it is lymphatic. Do creatinine and satisfy yourself. So now what you'll do now? Come on.
Sir, if the
It is a lymphatic. We
it
have
is
find
lymphatic.
out. Yeah.
Sir, so we'll start him on a low fat diet. Patient will be started on a low fat diet. So and then we will observe for the drain output again. If it is reducing by that, then good. If
So
it is
low fat diet, beta, low fat diet will act after how many days? Immediately?
no, sir, it will take time.
So what
It will
else
take
you want to do?
we can give the patient octreotide or sir oral drug in the form of sir, is it an it is right, sir.
वो जस्ट तुम्हारे सेंटर में ट्रांसप्लांट के बाद ऐसा हुआ तो क्या करते? 3 दिन से
Sir,
परसिस्टेंटली 400 ml.
sir, we will withdraw drain a little first.
Exactly to say, na?
Yes, sir. Yes, sir. Withdraw drain a little. Yes, sir.
Yes.
Yes, sir.
So start withdrawing and see what is the response.
Yes, sir.
That is number 1. Number 2.
Low fat diet, octreotide, and
So that you
is it
already started. Low fat
is it
diet,
an
and you withdraw 1 centimeter for next 2 to 3 days because you don't want the drain to come out. Correct?
Yes, sir. Yes, sir.
Then
Sir, oral drug in the form of sir azitanib.
okay, I am not given.
Yes, sir.
Abhishek, in your center, what you do?
Sir, we either withdraw the drain a little, withdraw the drain a little bit, or we instill betadine into the drain,
Betadine.
sir.
Yeah, so
Betadine or
betadine,
doxycycline.
yeah, sometime these are all not given in the books, but just practical
Yes, sir.
thing. Some people even start anti-filariasis treatment also. But
Yes.
how much helpful it is, we don't know. But yes, you withdraw the drain. Some people put betadine also inside. Some people have tried even tetracycline.
Yes, sir.
And if usually it stops. So it
So
may stop in
now,
next 7 days.
yes, sir. So now if the collection, sir, keeps improving and associated urine output drop and creatinine raised, I mean, creatinine starts increasing, sir, then we consider re-exploration and marsupialization of the lymphatic pouch, sir.
After doing sonography. If
Yes, sir, after doing sonography, of course.
yeah, so if after doing sonography, if you see that there is some collection which is pressing, then yes, you will go ahead. If nothing is there, then the cause is something else. So the answer is, in such cases, usually we have to wait for next 7 to 10 days. Don't be in hurry. If the clinically patient is fine, if you have done the sonography, if the creatinine is okay, everything is within normal limit, then just withdraw, put betadine if you want, and wait for some days. Usually it will stop.
More so even, sir, when the drain is progressively decreasing, sir, say after post-op day 10, 12, then, sir, we apply a colostomy bag around the drain and we discharge the patient, sir.
Yeah, some people do it, but while doing that, later on patient, initially there may not be any fluid collection, but later on,
There is a risk, sir.
yeah, lymphoma or something like that comes up after 6 months, after 1 year. So it is always better to keep the drain till you are happy that the drain fluid is less than 50 or 20 cc, 30 cc, and then you want to remove it.
Yes.
Fine. Okay, I think that ward round is over. We have covered almost everything. It means whatever is coming, and all of your exams are starting on, I think, 22nd, 23rd, 26, 27, 28, 29, and 29, 30. Correct?
Yes, sir.
So these are the dates.
Yes, sir.
So, and I think some students have already finished their exams. So, all the best to all of you.
Thank you, sir.
Thank you, sir.
And yes, so now we'll see you as a consultant, and we'll see you in conferences and also in this teaching program whenever you are free and you want to help us.
Thank you, sir. Thank you so much, sir.
Thank you so much, sir. Thank you so much for everything. Thank you, Gite, sir.
Best luck for all the students. Only one request is, it is not necessary to answer each and every question within
Yes,
a
sir.
second. Think over it.
Yes,
Try
sir.
to
Yes, sir.
answer with you, whatever you are doing at your center. Don't stuck with basics. Don't do blunders.
Yes.
Yes, sir.
इतना अगर कर दिया तो पास हो जाता.
All of you know theory very well. Please, now it's a practical exam.
Yes, sir.
So answer for a practical, not for the theory.
Because one examiner is asking one question, another examiner is asking in between another question, third will ask another question. So answer one at one time. And if you
Yes,
know
sir.
perfect, can only answer. If examiner is trying to misguide you, think over it and try to rectify it. But don't argue with the examiner.
Yeah.
Yes, sir.
Yes.
Okay. Thank you.
Okay.
Good night.
All the best. All the best.
Everybody.
Chalo.
Thank you, sir.
Thank you, sir.
Thank you so much, sir.
Thank you
Yes. And just give all of your response after the exams are over.
Sure, sir.
Yes,
Yeah.
sir.
Okay.
Thank you, sir.
Bye.
Thank you, sir. Good night, sir.
Good night, sir.